Hello, my name is Gilles Salles from Memorial Sloan Kettering Cancer Center in New York, and I'm happy to discuss with you today recent findings regarding the development and clinical activity of drugs that target the EZH2 pathway. EZH2 is an enzyme that is involved in the regulation of gene expressions in B cells within the germinal center. As you know, most of the lymphoma, B-cell lymphoma, and more specifically follicular lymphoma, originate from this region. And it has been shown that EZH2 actually controls very closely a key number of gene expressions involved in cell proliferation, regulation of immune interactions, and even apoptosis during this process. It was also found that about 20 to 25% of follicular lymphoma have mutation of EZH2, which promote the activity of the enzyme. And those patients may be highly sensitive to the inhibition of EZH2. But in fact, there is a rationale to inhibit EZH2 in both mutated and unmutated case, given the fact that this enzyme and the epigenetic complex in which it interacts basically control the biology of germinal center B cells, and particularly in follicular lymphoma. For this reason, inhibitors of EZH2 have been developed, and the drug we'll discuss today is tazemetostat, which is the first oral inhibitor of EZH2. This drug was developed in phase 1 study showing a satisfactory safety profile and some activity both in follicular and diffuse large B-cell lymphoma from germinal center origin. But what led to the approval of this drug in patients with follicular lymphoma was a phase 2 study enrolling patients with both unmutated and mutated EZH2 follicular lymphoma as single agent in patients in the relapsed refractory setting. So let me take you through the data of this study. Patients were enrolled in this study to take tazemetostat at a standard dose of 800 milligrams per day. In patients with the mutated form of the enzyme, which the overall response rate was 69%, with a complete response rate of 13%. In the patient with the unmutated form of the enzyme, the overall response was 35% and the complete response rate of 4%. We have to be very careful in comparing this response rate between these two cohorts, given the fact that they were not necessarily the same patients, nor the same characteristic and the same previous disease history, since it has been reported that patients with EZH2 mutation with standard of care therapy do better than the other one. So it's likely that the patient with unmutated were more severe and hence maybe the lower response rate. But these data were encouraging, including this overall response rate and CR rate. What was also even more encouraging was the fact that the duration of response for this patient was quite impressive for single agent therapy. In fact, the median duration of response for patients with mutant EZH2 was almost 11 months, more precisely 10.9 months, and was of 13 months, so more than 1 year, for patients with wild-type EZH2. Similarly, the median progression-free survival of both cohorts was nearly similar, with a median PFS of 13.8 months for patients with mutant EZH2 and 11.1 months with wild-type EZH2. So again, what you see here is an activity that is equivalent in both cohorts regarding median progression-free survival around 1 year and median duration of response around 1 year and higher. And again, this benefited to both patients with mutant EZH2 and wild-type EZH2. And this led to the approval of the drug. But before that, let me go over the safety of this combination. While the majority of patients in the trial had at least one treatment-emergent adverse event, only 9% of the patients had a treatment-emergent adverse event leading to dose reduction of tazemetostat. 27%, one quarter of the patient, had adverse event leading to dose interruption. But again, only 8% of the patient discontinued tazemetostat due to a treatment-emergent adverse event, and only 5% in total were considered to be treatment-related. So you have a drug here, which is an oral drug, which is for the majority of patients well-tolerated. About one quarter of the patient had the dose interruptions, and less than 10% had a discontinuation, and with the minority of them being drug-related. What was this treatment-emergent adverse events? Well, some of them are very common in patients with relapsed refractory follicular lymphoma. Again, this was patients mostly with 2 or more lines of therapy, and this included standard side effect, grade 1 to nausea, diarrhea, asthenia, and fatigue. There were a few infections, but in fact, grade 3 infections were rare and not really observed in less than 5% of the patient. There were a few hematological toxicity, and there were less than 5% of anemia, thrombocytopenia, or neutropenia in total. So again, a drug that is well tolerated, common side effects that you will find in this patient, limited hematotoxicity with a limited number of patients presenting with grade 3 or 4 anemia or thrombocytopenia. So based on these data, the drug was approved for patients with follicular lymphoma in the relapsed refractory setting, with a potential to use the drug in patients with a documented EZH2 mutation after 2 prior lines of systemic therapy, and overall for all adult patients in relapsed refractory follicular lymphoma who do not have another satisfactory alternative. So nowadays, we can use this drug in patients with a relapsed refractory follicular lymphoma, at least in countries where it's available, mostly United States, as a treatment oral that is usually well tolerated and given to patients to control the disease for a substantial period of time. I should add to the side effects something a little bit specific, which is the possibility of alopecia in patients that are women, which is not encountered in male patients. But the development of the drug will not stop with this single agent data, and there are ongoing clinical trials with combination. In fact, as I mentioned, this epigenetic mechanism in follicular lymphoma also made profound modification in the B cell and T cell interactions in this neighborhood. And there is a rationale to associate tazemetostat with other immune-based therapy in follicular lymphoma. One of the key studies that is currently running is called the Symphony study, in which patients with relapsed refractory follicular lymphoma after 1 line of therapy are currently randomized between the combination of rituximab lenalidomide, the R² regimen, versus rituximab lenalidomide plus tazemetostat. And the study is built upon a phase 1 study where this combination was tested, and we presented this result at ASH 2 years ago, showing that this was a safe combination, very efficient, with more than 90% of the patient responding to this triplet combination, with more than half of the patient having a complete response. And this was true whether patients were, again, mutated or unmutated for EZH2. Other trials are going in certain centers with combination with other forms of immunotherapies. And I think you should stay tuned on this topic, given the activity of the drug. Again, the first inhibitor of EZH2, now available for patients with follicular lymphoma. I thank you for your attention, and I hope this program will have helped you to understand the mode of action, the result, and the development of this drug in patients with follicular lymphoma. Thank you.